My name is Dr Parviz Sadigh. I'm a UK-trained consultant plastic reconstructive surgeon. My area of interest is microsurgical reconstruction. I was working in London up until last December before I made the move out to Dubai. So, look, generally in surgery, whether or not you're a candidate for a particular procedure depends upon local factors relating to the area that we're going to reconstruct and systemic factors relating to the general health condition of a patient. So with regards to breast reconstruction, firstly, you've got to be systemically suitable for a long operation and a inpatient stay in hospital. So generally what that means is you've got to be fit for a general anesthetic. So as long as you don't have metastatic disease and you're fit for surgery and the anaesthetist has deemed it safe to have you asleep on the table for up to 6 hours, then you're systemically fit for a breast reconstruction. With regards to the local area, namely the breast, that's to be reconstructed, things that would favor a reconstruction would be the suitability of the vessels for a free flap reconstruction, whether or not the area has been damaged by radiotherapy, whether there's any infection present in that area. Having said that, even if these factors are present, you can still undergo a reconstruction. It just makes it slightly more complicated. If the area is free of radiotherapy, free of infection, and the recipient vessels are healthy, then that would be favorable for reconstruction. Metastatic cancer means cancer that has metastasized, which means cancer that has spread to other parts of the body. And if that's the case, then we tend to treat the cancer as opposed to contemplating a reconstruction at that point, because the most important thing for the lady at that point is treatment of cancer and to gain cancer-free status before then considering a reconstruction. The take-home message is that chemotherapy delays wound healing or can impair wound healing. So oncologists will be very reticent to start a patient on chemotherapy if they have an open wound, for instance. So if you have let's say a mastectomy, the oncology team will generally wait 6 to 8 weeks before starting you on the chemotherapy to allow everything to heal. If you have a mastectomy and a reconstruction, if everything goes well, you can then go on to have your chemotherapy plus or minus your radiotherapy thereafter. However, if you have your reconstruction and an area of the flap breaks down or doesn't survive, or you run into a complication with that flap that then leads to delayed wound healing, your chemotherapy will then be delayed. So that is something important that the patient needs to understand and contemplate in their decision-making process as to whether or not they want to undergo an immediate flap reconstruction or whether they want to have a simple mastectomy and a delayed reconstruction once they've completed their chemo and radiotherapy. The simple way to divide this up is into implant-based reconstruction and autologous tissue reconstruction. What I mean by autologous tissue is using your own body tissue. Okay, so if we talk about the implant-based reconstructions, that's simply using a silicone breast implant or a saline implant or an expander, and we place that under the skin of the chest after the mastectomy, with or without local tissue to provide some more skin coverage. And then if it's an implant, we can then expand the implant up, or if it's a expander, we can expand it up. If it's an implant, we can use different sizes. With autologous tissue, we're using your own body tissue. So we transplant essentially tissue from somewhere on your body up to the chest wall. And ordinarily with microsurgical expertise, you can then reconnect the artery and the vein that supply the piece of tissue that you're transplanting to an artery and a vein in the chest. So in plastic surgery, one of the central tenets is to replace like for like. So if you can imagine what your breast tissue is, it's essentially skin, glandular tissue and fatty tissue. Where can you find similar tissue on your own body? Oftentimes it's the lower abdomen, if you have a little bit of excess skin there. And that actually is the same tissue that we remove in an abdominoplasty or tummy tuck. So essentially we're doing a tummy tuck, but instead of throwing that tissue in the bin, we are dissecting it out very carefully on its artery and vein, which is supplying it with arterial blood, and transplanting it up into the chest wall. So that's known as a Dieppe flap reconstruction. With that, you get a tummy tuck as well as a breast reconstruction, and there's no need for silicone implants. Indeed, if you don't have enough tissue in the lower abdomen, we can take tissue from other parts of the body, namely the buttocks, the back, or the upper groin. And these are things really you've got to discuss with your plastic surgeon, and after an examination of your body habitus, one can come to a decision as to what is the best form of autologous tissue reconstruction for that patient. So in synopsis, you've got implant-based and your own body tissue techniques known as autologous tissue. What I would say is if you're going for an implant-based reconstruction, it's important to ascertain whether or not you're going to need to have post-operative radiotherapy. If you are, all data to date suggests that you've got an extremely high risk of running into problems with your implant-based reconstruction, namely something called capsular contracture, which is where the scar tissue that forms around your breast implant contracts and leads to a painful, distorted breast, which requires further surgery. So my advice would be, if you're going to have post-op radiotherapy, you need to consider either delaying your reconstruction or having an autologous tissue reconstruction. Okay? If you're not having post-op radiotherapy and you're having an implant-based reconstruction, you can either have an expander, which is essentially a silicone balloon that your surgeon will then blow up with saline during a period of time after your reconstruction to get to the exact right size. And then at that point, they can exchange the expander for an implant of that size. Alternatively, you can go for a fixed size, which prevents you having to come back to clinic and have the expander blown up with the saline and multiple visits. We tend to use nano-textured implants these days. Textured implants are associated with something called ALCL, anaplastic large cell lymphoma. It's a very, very, very rare form of lymphoma associated with breast implants. So we tend to either go for smooth or nano-textured. Again, this is something a little bit complicated and something that I'd advise you can consult your surgeon about. But essentially, I would say the take-home message should be, if you're going to have radiotherapy after your mastectomy, either avoid an implant-based reconstruction, go for autologous, or go for a delayed breast reconstruction. So it depends if you're having a free flap reconstruction. So if you're having a free flap breast reconstruction, so for instance taking the Dieppe flap, which is essentially the lower abdominal tissue as a flap transfer up to the chest, that will probably take between 5 and 6 hours. In some centers that do high volume, it can be reduced slightly, and it also depends upon the recipient vessels and whether you've had previous radiotherapy or not. But I'd say as a ballpark figure, you should be thinking at least 5 to 6 hours. Generally, it's an all-day operating list, so you'll be the only patient on that surgeon's operating list for the whole day, and you'll be staying in hospital as an inpatient for a minimum of 3 to 4 days. If you're having a local flap reconstruction, so for instance where we would rotate some tissue from the back to the front, that takes much less time, because you don't need to reconnect the arteries and the veins to recipient vessels in the chest. So normally, for instance, a latissimus dorsi or LD flap reconstruction is normally done in conjunction with or without an implant, may take about 3 hours to do. So if you're having generally with mastectomy, it depends on the type of cancer. And that's something really to discuss with your breast surgeon who's going to be performing the mastectomy, and that's a decision for the mastectomy surgeon. Often the nipple is sacrificed because that's often where the tumor is lying in the glandular tissue. So generally, in my experience, it's quite rare to see a nipple sparing mastectomy, but we do sometimes see it in prophylactic mastectomies. But generally, where there is active cancer, the nipple often has to be sacrificed. Now, after you've had your breast reconstruction, there are techniques that we can adopt to reconstruct your nipple. We can either take some of the nipple from the other breast and transfer it over as a graft. It's known as nipple sharing. We can reconstruct the nipple using flap techniques on the breast. But actually, in my opinion, the most effective way is to do a 3D tattooing technique, which gives you a really nice visual result with no need for any further surgery and scars elsewhere on your body. So again, that's something really that you need to discuss with your surgeon, and it depends upon the size of your original breast tissue and how it matches to the other side. So if, for instance, you have a very large breast and you have a mastectomy and a reconstruction, it may be that you want to reduce the other side to match your reconstruction. That can be done at the same sitting, but again, it increases the operative time and the complexity of the surgery. So it's something to consider and to discuss with your surgeon. But there are techniques that we can do to lift and reduce the other breast to match the reconstructed breast. In addition, you can increase the size of the other breast to match your reconstruction with the use of either fat grafting or implants. So it really depends upon essentially the size of your reconstructed breast, and you can then either increase or reduce the other breast to match it. Generally, I would say no. There are surgeons and there are techniques available to us when we do free flap reconstructions, let's say using the Dieppe flap, where you can take a sensory nerve that supplies the tummy tissue down below the belly button region, and we sew that nerve into a sensory nerve in the chest. So there are papers, there are surgeons who do offer that, and you can gain sensation. But generally, it's not done. It increases the complexity of the surgery, increases the time on table, and it's something I'd say to discuss with your surgeon. Most don't offer it, but it is something that if you're particularly keen on pursuing, it is possible. On the reconstructed breast that's been removed, no, they can't, because the lactating ducts have been surgically removed. So on that breast, no, that's not going to be possible. But if the other breast has been unaffected, then yes, they can continue to breastfeed on the other side. So again, it depends on what type of reconstruction. So you've got, as I said, you've got your implant-based, your autologous-based reconstructions, or combinations of the two. I would say, as a general rule, for autologous-based free flap reconstructions, you've got to expect a longer operation, a longer in-hospital stay, up to 3 to 4 days, or if not longer. You've got a higher risk profile of things going wrong in the short term, but then long-term results are excellent. And as long as you get through that initial period, you're likely to have a lifelong excellent breast reconstruction. That's not going to require many or any revisions. However, if you have an implant-based reconstruction, your initial hospital stay would be much less. Your primary wound healing should be quicker. However, down the line, you're more likely to run into issues with the implant and require multiple revisions down the line. So it often isn't a reconstruction for life and will require further work doing. My advice for any lady undergoing a mastectomy with reconstruction would be to engage with your breast surgeons, your mastectomy surgeons, as well as your plastic reconstructive surgeons, who can offer you the whole remit of reconstructive techniques available to you. So as I said, you've got implant-based reconstructions, but you also have autologous-based reconstructions, which involve the use of free tissue transfer from other parts of your body. This can give you excellent long-term results, but you need to find a surgeon who can do microsurgery and is trained in these techniques to offer that to you. So engage with as many clinicians as you can in order to give yourself the best chance of getting an excellent cancer outcome as well as a reconstructive outcome.